We'd like to welcome you to the Healthcare Revolution podcast, where we empower you to take control of your health, restore your trust in the medical system, and achieve lasting wellness. I am your host, Brad Powell, Doctor of Physical Therapy and owner of an award-winning foundation physical therapy here in the Salt Lake Valley. Each episode, we dive into all things rehab prevention, overall health, bringing you expert insights from leaders across the healthcare fields. Please note, while we aim to provide with the best knowledge and advice, the opinions shared represent those of experts in the field and are not to be replaced with professional medical advice. So let's revolutionize healthcare and wellness together. Welcome to the podcast this morning. I'm so excited to have with me Dr. Jeremy Joyal, who is an absolute expert in treating low back pain. Today, we are talking about a better way to treat low back pain. So excited to talk about this topic. Jeremy was one of the first pain physicians I ever worked with and gave me a lot of hope within our healthcare system. And to be honest, he's played a huge role into what the healthcare revolution is all about. And that is working together as a team, because he showed that and demonstrated that early on in my career. And it's really helped me develop a better mindset around working with people that have back pain. As we know, low back pain is the number one cause of disability in the United States and worldwide. It's just such a big deal, and we have outdated systems, clinical practice guidelines. People are really fear-based when they have low back pain and are just really hard to move. They're confused on advice. They're getting conflicting advice. But millions of people bounce between different scans, imaging, prescriptions, specialists, without ever really learning how to get to the root cause and figuring out their problem. So today's episode is reframing that idea of the best way to treat low back pain in our opinions, but also clinically, what the research says as well. So Jeremy Joyal is a board certified anesthesiologist. He's in pain medicine, addiction medicine, absolute expert in those areas. He owns one of the most prestigious clinics here in Utah and just runs a phenomenal team. Just does such a great job. His focus is on modern patient-centered approach to the spine and nerve-related injuries. He's passionate about reducing unnecessary surgeries and empowering patients, and he collaborates really close with other healthcare providers, including me as a PT, which I really respect, and just really spends a lot of time in those strong relationships. So he brings in just so much background, so much knowledge in this area, and I'm so excited to be able to share his knowledge with you. And he's been on the podcast before, so welcome again to the podcast.
Thanks for having me again.
Always a pleasure, Jeremy.
Absolutely. The collaboration has been great over the years, so it's fun to do something like this as well.
Yeah. You really opened my eyes to so much early on in my practice. Just a young clinician coming out of school, 2 years out, and I can't even remember how we first got introduced, but you have changed my practice in so many ways, and I'm so grateful for the first early interactions and how they have led to really thousands of patient success stories over the years.
Yeah, for sure. Well, that works in our benefit as well. It's fun to chat with you about the business of medicine sometimes as well, but being able to have frank discussions with somebody about a patient that's struggling and all that has made it just that much more valuable and easy to help those patients get the progress they're looking for.
Yeah, so many people think that, I go to PT didn't work, I just go to surgery, right? Talk to us about like the in-between, and what we do in the PT world that can help pain medicine, and then what pain medicine can do to help PT world.
Sure. Boy, there's a lot that can be done short of surgery for low back pain in the interventional space. Low back pain can be extremely complex because it's a really complex set of anatomy. There's the bones of the spine, they're supposed to be mobile. So that involves some joints, there's ligaments, the discs, the nerve spaces, and then the muscles that kind of move all that. So it can be really complex in some situations. And our job is to help diagnose and establish a priority list of what is the most probable pain generator, address that, and work our way down the list. So a part what we do is figure out what components of the anatomy are causing the pain, try to address that through different means, but also educate patients on we really are fighting a chronic condition like diabetes in a lot of these cases. And we there isn't a cure, so to speak, all the time. Sometimes it's a management tool that will need to be used periodically throughout their life. And of course, we use these management tools to get gains in pain relief so that they can be more functional. And that's where we rely on you and your colleagues to help our patients get that rehabilitation so that when the benefits of whatever treatment we provide kind of run their course, that they come out stronger on the other side of all that.
Yeah, absolutely. And, a lot of the studies that we look at in the PT world is, low back pain, it's going to come and go. Mm-hmm. The real purpose of going to physical therapy is to reduce the recurrent rates of low back pain, right?
I agree 100%.
We want them to not have it nearly as much. And when they do have it, it's going to be significantly less intense and less frequent.
Yeah. And part of it is also learning how to decrease their chances of flare-ups as well. Like I tell my patients all the time that you can't just go do your therapy and quit and expect to have, forever outcomes. I tell my patients, I want you to learn the tools that you can use when you have some flare-ups, so you can kind of work through it as much as you can on your own without necessarily having to come in and pay co-pays and all that stuff. We want them to be able to be free of the medical system as much as possible, but we're here for them when that runs its course.
Yeah. And I love some of the procedures that you do in your clinic because, when I first started PT school and throughout PT school, I thought, it was kind of this like silo care mindset where we just like get patients in, we see them for, 12, 15 patient visits. And if they didn't get better, that's all we got, right? Yeah. We tried our best, you know what I mean? But now you've kind of taught me this model that's worked really well for us. If I am 3 visits in as a PT and I'm not making progress, immediately I'm getting you on the horn, right? Like I'm calling your office, like getting them into your clinic. I can't tell how many times you bailed me out. I'm like, dude, I cannot get this pain down with this guy. Is there any way you can get him in? And I've even called you like with emergent cases. I'm like, I need your help. You know what I mean? And that's really what we're here for each other for, right? Yep. It's like we need an extra hand. Like this is not, I can't get what this patient needs right now. And you get him in for an injection and you get that pain way down. They come in the next visit and all of a sudden we're moving. And the time in which we collapse for the patient is so significant. It is literally one of the best ways to treat.
Yeah. Those are the things that keep us coming back to our clinics, right? To help those patients, and that collaboration is the key to, the faster patients can heal and recover, the less likely it is they have to deal with a chronic problem. Yeah. We're trying to prevent the chronification of pain.
Yeah, absolutely.
With this model.
And we've talked about in the past, back pain's a protective response, not necessarily a sign of damage. Tell us what you see on MRIs and the correlation or causation. Like, does what you see on an MRI always reflect what the patient's feeling?
It'd be nice if it did, but that's not the case. I see patients coming in with horrible back pain, but pristine looking MRIs. Conversely, I see my old patients coming in with absolutely destroyed looking MRIs, and they're walking and they say, I feel great. I'm here to talk to you about my ankle or something like that.
And you're like, wow, I had like 7 things I needed to do on your spine based on the image, but correct. That's great. You have no pain.
Correct.
Tell us why that is.
Oh man, I wish I knew.
Wouldn't that be nice? Back pain was so simple in school, and the hundreds, I would say even thousands that I've treated now, the more I've treated, the more I realized it is really multifactorial. There's so many things to take into consideration with low back pain. It's not just one.
100%. Yeah. And why some people aren't symptomatic, some of that is through adaptation. And, there's a lot of other factors that go into pain, the psychosocial environment, and expectations, and so some people just learn how to deal with some minor complaints and better than others. That's the reality. But sometimes they just really have adapted to those chronic changes, and it's fortunate for them. It's not that case for everybody, of course.
Yeah. And there's so many different ways in which pain happens. You're kind of talking about cases where people adapt, their brain adapts, right? If they've been in pain for so long, the longer you're in pain, the more your body starts to remember that pain. And typically it's going to associate with a stressful situation. You're stressed, you're anxious, all of a sudden you start having pain, right? It connects to a different system. And that's where we stay in this chronic cycle.
Correct.
Right?
Yeah.
And that's what you're talking about is adaptation, is your body is adapting to life, right? And then what's interesting is you change your movement patterns. The movement patterns drastically change, and you produce the same pain with those movements. It's just repeated over and over. So until you're trained how to get out of those movements, you just have recurrence over and over again.
Yeah, we see that quite a bit, and that's what that's where we're trying to disrupt those pain signals with our interventions and whatnot, so they can learn how to move correctly again, so to speak.
Yeah, because the thing is, if you're in pain, of course you're going to move differently, because your body is just unconsciously going to say, I don't like that. I'm going to move slightly different so I don't have to feel that, right? And remember, pain is a signal. It's not saying that there's tissue damage. There could be tissue damage, but if you had 3 months, there's no longer tissue damage, most likely there. It's healed. Your body is just figuring out, it's tensing up. It's protecting against that certain movement, right? So what we do in therapy is, say you do an injection, you're blocking that pain signal. That's beautiful for us. Because all of a sudden we start to move into those patterns that cause pain, and that's actually typically the answer to getting them better. It's actually gradually move into that. I had a guy, my neighbor, he was, his wife called me and said, Brad, I won't tell his name, we'll just call him Joey. Joey's in bed. He hasn't moved in 5 days.
Oh my gosh.
He's in excruciating pain. I don't know what else to do. I'm going to call an ambulance. And I'm like, is it his back? I'm like, I know this guy, right? I'm like,
gotcha.
I'll come over to the house. This is on a Sunday. I'm like, I'll come over for 20 minutes. I'll get him out of bed. And I go in the house. I'm like, can you move your feet? Can you move your toes? Right? Just kind of going through our exam, making sure there's no trauma, right? You didn't fracture anything, right? No cancer, no issues like that. I'm like, all right, well, show me you move your pelvis. And he's moving his pelvis, and you're like, oh my gosh, that feels so good. He was fearful to even move because he thought his back was going to blow up.
Yeah.
Right? But we start moving, and he's like, oh my gosh, that feels so good. Got him over to the toilet. He used the bathroom for the first time in 5 days. Then ended up taking a shower that day. And then all of a sudden, he's feeling so much better. Why? We're freaking moving. You're getting blood flow, right?
Yes.
The body is going to tense up because it's fearful, and we're getting it moving and desensitizing, right? But what I like about the collaboration between us is sometimes the movement actually causes more pain. And we can't bring it down to such simple movement without causing it. And we'll use tools. Sure, we'll use dry needling and cupping and massage techniques to get it to calm down. But sometimes the nervous system is so hypersensitive that we need your help, right? Tell us about some of the procedures that you do that can help calm these muscles down, that help patients in physical therapy.
Sure. So a lot of times muscles are reacting to, a more internal structure like discs. Let's start at the disc. So discs can cause pain when there's a tear, and the jelly filling can migrate into the part of the disc that has nerve endings in it, and it can cause what we call discogenic pain. So usually we'll do a steroid injection, trying to calm down the inflammation, and it won't heal the disc tear, but it can at least reduce the inflammation, because it's that inflammation that makes the nerves more sensitive, meaning it's easier to fire pain signals. Those pain signals are stronger and they last longer from minor insult. So really what we're trying to do in the situation of a simple disc tear, which is really easy to do, you can, just lift with poor technique or something like that, and you can trigger that. But what happens to the back is the back will automatically the back muscles will try to automatically stabilize the area around that disc so that disc doesn't move.
Yeah,
and
muscles all tighten up and start spasming, right? Because they're trying to guard and stabilize the area that's hurt.
You bet. And so, and that's the acute response to an injury like that, the early response. And then, so we want to intervene as soon as possible so that doesn't become like fibrotic muscle tissue from the lack of movement, you know? So that's where the two-pronged approach of some interventional help from us and then the movement, education and assistance from your team can really help patients heal quicker.
Yeah.
So that's one example. Other areas we look at are the interface of the disc and the vertebrae. So the discs sit between, an upper and a lower vertebrae, and that interface can become pretty painful. So there's not a ton of nerve endings in discs, but there's a ton of nerve endings in the surface of the vertebrae that sits on the disc.
So pretty much where they articulate together.
Correct. And that's called the vertebral end plate. So there's a procedure where we essentially deaden the nerve similar to a root canal procedure in the mouth, where the nerves won't be able to send the pain signals that cause these reflexive muscular issues. And that's a procedure called basivertebral nerve ablation. So that's been really successful. We've been doing that since about 2020. And
super simple procedure, right?
Pretty darn simple.
Very minimal invasive, right? You're just kind of making a small incision, a camera.
It's all done with fluoroscopy or live x-ray, but teeny little incision. It's so small I don't even suture it up, just a little tape and glue, and patients go home the same day. Most of our patients come back at 10 days saying they feel some changes happening. They're still recovering from some muscle soreness and things like that. And then usually by 3 months, they're feeling game-changing pain relief.
Yeah, and in the PT world, if I'm working with a patient and I'm like, first couple visits, we're not making big changes. With back pain, if I'm not making good changes within the first 1 to 2 sessions, like it's not musculoskeletal in my mind at the level I want it to be, unless I'm making quick changes, right? So that's where I love getting you involved, do an injection or whatever you prescribe, right? And then they get back in, they keep moving, we keep learning these muscle patterns, balance out mobility and stability of certain muscle groups, get the fear avoidance to go away, meaning they're not scared to go into certain things. We're gradually working in different areas. And then if we're still not making progress after an injection, I'm getting them back to you to talk about possibly something like this, an ablation, right?
Perhaps,
because you're kind of deadening the nerve to calm the muscle down even more. You're not cutting the nerve, right? And nerves, these types of nerves all kind of regenerate as well. So is that correct?
The basivertebral nerve inside the vertebrae is different than some of the other ablations that we do. So that nerve actually doesn't reconnect after we treat it. So, and that's why I use the analogy of a root canal. Once the root canal is done on a tooth, pain signals cannot leave the tooth, but the tooth functions normally and it maintains its normal structure, so that type of ablation is a one and done for a lifetime, which is really nice. And that's why if a patient's a candidate for that, I'd like to talk about that early on, because if I do something that can last a lifetime, that can exit them from the medical care system, quicker, which is what we're hopeful for. It's what I would want for myself. I would like to not become dependent on the medical system to manage my pain. And so if we have long-term options, we like to look at those first. And then we have some other ablations where we essentially deaden the nerve supply to the facet joints. And those nerves for the facet joints actually do regenerate generally within 12 to 18 months. Sometimes I've had patients come back after 4 to 7 years. But reliably, we can say if we treat the nerve responsible for facet joint pain, we anticipate at least 1 year to 2 years of really good pain relief.
Yeah, and I would argue with those ones, You know, a lot of people say, like, well, my injection has wore off or my ablation has worn off. If really the purpose of these interventions is to get you to move better, right?
Yeah.
People move better, and who knows and who cares if it was the injection that, you know, did the job. You're moving better, right? When people say it's wearing off, it's kind of hard to say. Is it wearing off, or are you just still moving in a certain way that's causing the pain? Are you lifting in a certain way that you're loading your back too much, right? For instance, if someone's going to go out, they don't lift weights, they don't exercise, and they're like, I'm going to go sod my yard for 6 hours, and I'm going to be bending at the spine 300 times with a lot of load. We all can know and appreciate that your spine's not ready to tolerate that load, right?
Right.
And it's not that the injection necessarily is wearing off. It's most likely you just made it mad again.
Yeah, that's right. Re-injury, re-diagnosis is what needs to happen when, you know, we have a period of good pain relief and then there's a recurrence. You know, we don't want to just say, oh, it's probably the same old thing. We want to be smart, re-examine, maybe update imaging if we need to, just to make sure we're not getting stuck in a rut.
Absolutely.
So
tell me what the purpose of imaging is for you.
There's several things. Number one, we want to make sure our clinical diagnosis is as accurate as possible. So we use imaging to look for fractures and tumors and things of that nature, because all those things get treated way differently, you know. So if somebody has a fracture, we're going to, you know, work on fracture care first, and then we can look at some of those other more chronic injuries or chronic changes. We tend to prioritize treatment for nerve compression and nerve injury first because of the delicate nature of those nerves, and chronic nerve damage can happen pretty quickly. I'm talking about like the major nerve roots that run into our legs if we're talking about back pain. We want to prevent permanent nerve injury as much as we can. So we tend to be pretty aggressive when we see like an acute disc herniation that's compressing one of those major nerve roots. We tend to be pretty aggressive with the minimally invasive approaches, because if we don't get enough healing, the next step is going to be surgical. And of course, PT is playing a role through all of that non-pre-surgical phase. But if we really need to move a patient towards a surgical consultation, we do that because we're trying to spare, you know, as much long-term nerve damage as possible.
Yeah, because you can actually get permanent damage. I mean, the research really shows 80 to 90% of back pain is not really dangerous and is going to improve over time, right? All these interventions are there to speed it up, the recovery, but then reduce the recurrent rates, but then also to make sure it's not going to be a permanent thing, right? Like that, the 10 to 15%, if we don't catch those are significant things that could change your life, right? What are the symptoms that we're looking for? Someone that's got low back pain that might feel that they're not part of that 80, 90%. The ones that are really severe, these nerve type ones. Give us some of those symptoms.
Yeah, so it'll be pain that kind of is like electrical and traveling away from the spine, and it can go to the fronts or backs or legs and travel down to the feet. So it feels, it's very intense, very localized, but it does radiate and travel.
It's got the leg symptoms. So
correct.
It could be starting in your butt, work down your thigh, down into your calf, and then down into your foot.
Yep. So the first symptom will be pain, but then that usually develops into some areas of numbness or paresthesias, which are just kind of odd sensations like a vibration or tingling or walking on glass, something like that. And then it's really advanced when there's weakness of the muscles, because those muscles are responsible for controlling those nerves are responsible for controlling the muscles associated with those nerves. And if those nerves are compressed to the point where they can't fire the muscles that they control, that's a real big problem. That's a big red flag.
Yeah. And these symptoms that Dr. Joyal is talking about are so critical. If you're having them in the PT world, you know, if I'm writing my note, I write at the top, waitful watching. That's what we call it in the PT world, which means that we track these symptoms like crazy. Every time you come in, I want to check your strength. I want to test your reflexes. I want to test your sensation. Because if they're not improving over time, right? And I'm giving it 5-6 weeks, but every single week you should be progressing. If you're not, we got to get you into a surgeon faster.
Yes.
Because, the range, like if you have these symptoms over 9 months, like even over 3 months, it can cause permanent damage. And we just don't want to be irritating that nerve for any longer than it should be. So that's why we want to get on top of these things, right?
Absolutely. I mean, it's always surprising when patients come to me 6 months in and they're already weak, and
you're like, no.
Yeah.
6 months. We missed the mark.
Yeah. Especially in the younger 30, 40-year-olds, they're really good about just kind of sucking it up, biting their lip and trying to see if it'll get better, but we see a lot of cases where that, unfortunately, there's permanent damage done. So.
Yeah. And what we mean by permanent is you could have numbness for the rest of your life in certain areas. You could have weakness. We call it foot drop, where you're not able to control your foot anymore. Certain cases you lose bowel or bladder control. Yep. So these are big deals. You don't want these issues going forward. So when we see these clinically, we watch them like a hawk, and we're on high radar.
Yes.
Right? These are my favorite cases to treat, and actually the ones that I have the most success with, because I actually love measuring them, because we're very objective about it. We'll test certain muscle groups with a handheld dynamometer, and it will tell us how many pounds of force you can push into my hand. And then I'll track it the next time. I'll track it the next time. We'll check how many calf raises you can do on the one side versus the other side. Right. So it's very objective, what we're measuring. And the beauty is, when you have a discogenic problem, say you had a disc herniation, it's pushing on a nerve, it's compressing it. We're doing exercises. The worse it is, the farther it travels down your leg, right?
Agreed.
So it's peripheralizing when it goes into your foot, and it's centralizing as it comes to your back. And as it comes out of your foot into your calf, and then out of your calf into your thigh, we know it's improving. Right? So what we're looking for, I'll see in a session, if I'm working with one of these patients and it's going well, I'll see in a session, it was in your foot. Where is it now? Oh, it's in my calf. Okay, let's keep going. Where is it now? Okay, it's in my thigh. Great. We're on the right track. Right?
Yeah.
And then textbook wise is it comes out of the thigh back into the hip and into the back pain typically gets worse. And we usually say that in the beginning, like, hey, just so you know, as the symptoms come out of the leg, your back pain's typically going to get more intensified, because all the symptoms are coming back to the place where they started, and it's typically going to get a little bit worse, and that's when we know it's a good sign. But we try to warn people that early on.
Yeah.
But it's so rewarding clinically when you're working through that and the symptoms are coming out, the strength is coming back, the sensation is coming back, and they're so fun to work with. But on the other side, if it's not improving, and as providers or as the patient, you say, I'm just going to suck it up, or, we'll get through it. That's not the right course. You can really cause some significant things down the road.
Yeah. And your objective measures are refreshing. Whenever a patient tells me they've been to PT and it didn't work, right? That's the phrase we hear a lot. I always ask qualifying questions like, well, what did you do?
I love that about you.
And a lot of times, unfortunately, they said, well, the PT saw me for 5 minutes, then I worked with an aide, but the aide put me on an exercise bike. And that's the worst thing.
Nothing worse for my profession than that, man.
It's the worst thing for the patient, because it's not individualized care, you know? So that's why I think why we've worked so well together is because, our different approaches really provide for the best outcomes.
Yeah. And ultimately they are synergistic. They're assisting each other, right?
100%.
What I do here in the clinic supports you and your patient. What you do supports me and my patient. You know what I mean? That's why it's so powerful, because it's really a better way of treating the spine when we all work together, because you have pieces of the answers that I don't, right? We talked about
vice versa too.
The low back pain being multifactorial. Mm-hmm. There's so many factors. You hold pieces. I hold pieces. The patient holds pieces. chiropractors hold pieces, right? Each one of us holds a piece of the puzzle. And unless we work together as a collective team, we're really not doing the best care for you.
Yeah, we may not put all the pieces together, right?
And it's so hard because I'm trained in my world. This is what I see.
Yeah.
Do I have medication? Do I have these things that can calm down internally? Not as much, right? I have tools in my toolbox, but I only can go so far. And that's why we need to utilize each other.
Right.
What advice would you have for physical therapists that you've seen over the years, that things that have gone really well and things like, what would you say to the PT community about all this?
I would really say those objective measurements are helpful to see whether or not we're seeing the gains. And then we got to just make sure that the gains are what we expect. And it's those outliers that aren't, those patients that aren't gaining the way we anticipate at the correct speed. Those are the ones I would like to see sooner, so that we could potentially offer them, a pain relieving treatment that could potentially speed the recovery.
Yeah. Why do you think, the PT and pain physician collaboration is so essential? We've kind of alluded to a lot of it. What else would you add to that?
Yeah, I would say it's just we approach it from different strategies. So most of what I do approaches it from a structural perspective. Yeah. And you really approach it from the functional perspective a lot more than we do. So, and you what you do in your sessions actually helps the patients learn how to do daily activities, which we don't do as in our profession. So I think just the combination of things just give the patients real world healing with the fastest route to that.
Yeah. I'm just thinking about my kids and developing well-rounded children. Like, how do you do that? Do you do it just by you isolating them in the home and never letting them go out and be exposed to anything in the world? No, like, there's so many people involved in my kids' life. Soccer coaches, piano teachers, like, their school teachers, like, there's religion. Like, there's so many different people that they're exposed to. They're going to the grocery store. They're interacting with people. Like, they're getting this, like, well-rounded collaboratory experience of being raised, right? It's not just one parent raising a child. It's a community of people that are helping that child grow.
Yeah.
You know what I mean?
100%.
And that's why I really like treating back pain so much, because I've seen the best results working together as a team.
Yeah.
Like, hands down. It just works so ridiculously well. And I sometimes I get in a little bit of a habit of really challenging patients to go see someone like you to speed it up. If they're resistant to it, I'll maybe give them a little bit of extra education. But sometimes I'm like, I've seen the best results when it works this way. Would you be willing to at least go get a consult from Dr. Joyal so we can make this even faster? I'm fine if you're totally resistant to that, but man, it's made drastic changes for so many patients for me.
Yeah, and I think that's the right way to do it. Really just give patients options and let them choose, what they want to do. So that if a patient's reluctant to get an injection, I'm okay with that. We'll try to help them with whatever we can, whether it's medicine or whatnot. We try to reduce the opioids that are used and whatnot as much as we can, but can we help with some kind of anti-inflammatory or muscle relaxing agent, or are we looking at maybe we're dealing with some psoriatic arthritis, some kind of autoimmune disease? Let's get you to a rheumatologist or something like that.
Yeah, so absolutely. Let's talk about messaging for a minute. We all have different messaging, the way we explain things. And, we talked early on in the podcast, one of the biggest problems with spine care is people are getting mixed messages from different professions, right? one common thing that we throw around in really healthcare is kind of this jelly donut principle, right? Of like squirting out. And I think, as healthcare providers, we all know it's not literally squirt, you one wrong move and it's all over, right? It's not like this fragile thing. We've dissected humans in anatomy. We know you've done live, right? Like you do these surgeries all the time. Tell us what an actual disc feels like, a live disc that you are, as maybe herniated. What does that tissue look like? And what does a healthy disc look like?
Oh, so
is it really like a fragile donut that just like squirts with wrong on move? How's it look?
It's actually pretty fibrous. I haven't held a disc myself, but I put needles into the disc, and the disc it's a thick fibrous ring, and that's how it maintains its integrity.
What does fibrous mean to you? Like, how would you describe fibrous to listeners?
Boy. It's not flimsy. It's pretty rigid, but there is some give in it. So it's got the disc itself has multiple rings that give it structural integrity, but it is filled with a softer, squishy substance called the nucleus pulposus. One of the procedures that I've done is to extract some of that nucleus pulposus with a needle that has a powered auger that kind of sucks some of that nucleus pulposus out to relieve pressure off of a...
So to control or to compare it to actual jelly, I was just eating a PB&J sandwich the other day. Is it similar or is it very different?
It's different. So when we pull it out, it actually looks like cotton in a healthy person. But in a really, really chronically degenerative disc, it actually looks like kind of a charcoal slurry. So it's pretty interesting. I can show you some pictures sometime.
Awesome. I've done human dissection and done it on cadavers. And I remember we dissected every single portion. We even cut the certain organs in half to see the insides. We took a disc out and put it on a table. And I remember I had a sharp scalpel, right? And I stabbed it into this disc and I couldn't even get it through the fibrous portion.
Interesting.
It was like so stiff. And we were all like, well, what about this jelly donut? I'm like, I can't even get the scalpel through it. It's so tough, right? Because a lot of us just think like, oh, it's just going to explode with any wrong move, right? But the thing is, the disc, they do weaken over time if you load it a certain way, excessive amount of repetition or excessive load. It's not just like one wrong move and it blows up, right? Like my neighbor. It's like, I don't want to move because it's literally a bomb that's going to go off, right?
Right.
But ultimately, the nerves get irritated, and that's really what it comes down to. And if you've loaded that disc for excessive period of time with repetition or with excessive load in a certain way, that disc, sure enough, it can do the herniation, right? It can bulge, it can push against these nerves. But it does take a lot of load. We did studies where, I wish I had the reference to this study, but we put pistons on a disc to see if it was loaded appropriately, how much load could that disc take? And some were up to 3,000 pounds.
Yeah, it
right?
doesn't surprise me. Yeah.
But if we put that in like a cylinder and we compressed it, it could take a huge amount of load. And some up to 10,000 pounds. Right? So just excessive amount of load through one spinal disc. But then the minute we took the cylinder away, it didn't have support, structure. So say the muscles, live structure supporting the spine. It only took 15 to 20 pounds of pressure if it was alternated at an angle that wasn't intended, right? So the disc, when they're loaded appropriately, they can withstand a lot of load. But when they're loaded inappropriately, and we can talk about that in a minute, but it just doesn't take a lot, right? But we don't want people to think in their minds like it's just literally squirting jelly, right? It does take, a certain amount of load to do that. It's just not just a one wrong move. But tell me how messaging really influences patient behavior in your world.
Oh, yeah. It's kind of funny what ChatGPT and AI has done now, because it's actually better than WebMD, I think. I think patients can source a lot of good info, but there's still a lot of misconceptions out there, and really helping patients understand, because they'll use certain words that mean something to them, but it's not what you and I would talk about. So we really just try to get on the same page and make sure that we're communicating to the patient the way they understand it, but still also using correct principles and terms and things like that.
Yeah. And it is so challenging because you want to use analogies of how people can picture things in their head. But we've definitely learned over the years how some of the analogies that we've created can actually be damaging to them because they think they're fragile.
Yeah.
They think they're just going to break with one wrong move. But ultimately, one of the myths I hope to abolish out in the world is your spine is actually ridiculously strong. You have so much support, so many muscles that support the spine. So when I talk about 15 pounds of pressure, that's literally with no support at all. You literally have so many muscles that support. I don't even know the number of muscles that support every little joint in your spine. So you have so many ligaments supporting it, giving it structural support. We have so many muscles, tendons, just the bony structure alone. Like, it's not just living on some planet Earth by itself. It has so many different support systems that give it structural support that you need to be able to do all the things that you do.
For sure.
And, some people just need to hear that you are strong. Like, your body is not fragile. It's not going to break.
Right. And one of our jobs is to diagnose when it's not stable, and so we always look for those clues, because if patient has an unstable spinal segment, that could lead to injury with certain activities. And so we need to address it appropriately, sometimes even surgically.
One of the cases that we've presented together on, it comes to mind, our young gal that, she was in her late 40s. I was treating her. I treated her for like 5 or 6 visits. I can't remember exact, but just not responding well. And she's hurt her back lifting weights, just, late 40s, nothing crazy. And she's had crazy back pain. And, I've treated hundreds of cases at that point. And then she just complained, like, I was laughing with my friends last night and I just can barely walk now. She's holding on to her husband, linked arm to arm, walking in the clinic, just barely moving. And I just thought, I'm like, this isn't right. 45, late 40s, just not really responding to PT. We end up I sent him for an MRI. The radiologist called me before they left and said she's got 17 pathological spinal fractures, and she's got some growth in there. I don't know if it's cancer. I don't know what it is, but there's so much, so many tumors in her spine. It's literally corroded her bones, and now she has all these fractures, right?
Yeah.
And that was such a unique case, and unfortunately, we worked together on it, but she ended up passing away a few months later. But we got to catch these things.
Yeah.
We got to know when things are not right, because when they are unstable. But that is our job, is
Correct.
to, help people know when to go move your spine or when not to, when it's serious and when it's safe.
Yes.
You know what I mean? Is there any other messaging you hope to change in the world about backs? Like if the public, if you wish they knew one thing about spines, what is it you hope that they know?
I would say if you have pain, you want to address it as soon as you cannot manage it easily by yourself. Get that help early, so that way we don't lose the window of opportunity to do something that will provide lifelong benefit. So ask for help early.
Like when we get back pain within 30 days, how much easier is it to treat?
So much easier. Yes.
Once it's at past 90 days,
right.
Like how much more difficult is it to treat?
It can be really, really challenging.
Tell us, help the listeners understand why that is. Why would you want to get help within the first 30 days? If it's not improving. I love that you alluded to, like, try to do it on your own. But if it's not working and it's not working quickly, we need help.
Correct. Yeah, because there's decompensation just kind of moves from one system to another. Let's start with a simple disc tear again. Not dangerous, doesn't cause like the radicular pain down the leg, the nerve pain shooting down the leg, but it's just a backache. We know that muscles will tense up. After a while, the wrong muscles start to compensate for those muscles that are over tensing around the spine. Then as that disc, kind of compresses a little bit more, then that puts more stress on the facet joints. And there's a reaction at the end plates as well. So again, if we can stop that cycle of the disease moving from one portion of the spine to the other as soon as possible, then patients will do better for their whole life.
Yeah, it's so true. And, as you think about the word disease, just don't interpret Jeremy wrong here, because disease in most of the public's mind is like something that is contagious, that spreads. The disease that Dr. Joyal is talking about here is you start to load your spine differently, and it is spreading to the next joint because of the way you're moving. So it's not like it's just like some infectious disease that's spreading. It's purely spreading because you're moving differently.
Yeah, just
you're compensating through the next area, and it's injuring and causing long-term change through that next joint because of that compensation.
Correct. Yep.
And, the spine is so fun to treat. I love treating low back pain. I love treating any back pain. But it can be challenging, and ultimately what I found to be the best treatment is working together as a team. And that's the patient included. What do you hope the patients come to the table with? Like, what's helpful when they come to your office? What would you hope that every patient would come to your office with?
I would say an open mind and willingness to be part of their own solution. There's some people that just say, hey, give me the fix. Sometimes the best fix for long-term is to really develop a strategy that you use your whole life. That meaning instead of just going in and getting a surgical fix for anatomy, learn how to use your body the right way so you prevent injury and you have a routine that you can use on a regular basis to keep yourself as healthy as possible.
I love that. I kind of want to end with this piece. I really want people to understand, our profession's getting better, PT. We're still struggling in some areas. Our profession's not all on the same page, and we're getting better and better each year. I'm now working on the state level with, improving a lot of our profession. And the one thing I realized, if you're not getting a good team behind you, just find a new one. You know what I mean? And I love that you kind of vet out good PT versus subpar PT, because it really helps you figure out, do you still need to keep doing that and we need to get you somewhere else? Or did you actually have a good therapist that helped you through it? You know what I mean? But the early phases of therapy are getting your pain down, stabilizing everything, right? Yes. And then we go to phase 2. Yep. And I'm going to break this down simply. Phase 2 is we got the pain down. Now we're going to get the muscles firing, right? And get the right muscles firing in the right sequence. Mm-hmm. We're going to teach these muscles to function this way. Then we're going to work on mobility in certain areas. So your upper back should be very mobile. Your lower back should be very stable. So we might work on some stabilizing exercises of the low spine, mobilizing exercises, or motion exercises for your upper back, mm-hmm. right? And then even the hips, getting the hips real mobile, making sure they're not super stiff and guarded through certain areas that overload the low back. Because if the upper back is too stiff, it's going to demand motion through the lower back where the painful spot is, right? Yeah. But if we get the upper back moving really well, it won't demand as much to the lower back. Then if we stabilize the low back, get the muscles to coordinate well as you start to move, then it feels better, right? So then we start training all those muscle groups to work together well. We balance out the joint by joint approach. And then the last phase is the most important phase. It's when you're out of pain, you've trained all the muscles. It's the return back to life. And then I like to think return back to sport, work, whatever it is. I want to see them doing things that are harder than what they're going to do on their own.
Yeah.
I want you, I tell all of my therapists this, every patient should be doing a deadlift before they go. Now, let me be clear. deadlift is not the same for grandma 84 years old as it is for 25-year-old, right?
Yeah.
Everyone does a deadlift. I'll take that to my grave. Like, you pick up a water off the ground, you pick up a child, you're literally doing a deadlift. A deadlift is a hip hinge, you bend your knees. It's picking things up off the ground. Everyone needs to know how to do a deadlift appropriately. A deadlift loads the big muscle groups, your butt, right? The posterior chain is what we call it. If you don't know how to load those muscles and you're just loading the spinal disc of your bottom part of your spine, the lumbar spine, your discs over time will take a toll.
Yep.
But if you're loading the biggest muscle groups in your entire body and you're doing that consistently, that's where it should be. The loads should always go through muscles, not necessarily through specific joints, right? So we teach people how to hip hinge. We teach people how to load their big muscle groups. And then we teach them how to exercise those muscle groups so they stay resilient and strong. And then we watch them do all of the lifts that they're going to do at work. Tell me how this looks at work. What are you reaching around? How many repetitions are you doing a day? How much load are you doing a day? Okay, let's optimize your workspace so that way you're not recurring injury, right? Because you might be doing this thing over and over and you just have recurrent back pain because the thing you're doing at work. But if I can change how you move throughout the day, I'm going to change how your spine's loaded. So I'd say the most important piece to reducing recurrent back pain is to do the end phases of therapy, to push people beyond what they're going to push at home so we know how their spine is going to respond, right?
Yep.
So
that's why our patients do so well when they come see you, brother.
Well, thanks. It's, I think it's a key piece that we're missing in our profession because we get people out of pain. We're like, all right, you're out of pain, go.
Yeah. And patients have that mentality as well. It's like, I'm fixed now, great.
Yep.
But the maintenance phase is where I think the biggest struggle is. So
yeah. And I always, in the beginning, I think one thing that we do really well in our clinics is setting expectations. Mm-hmm. We always say in the beginning, like, imagine this is like an antibiotic. You have an infection. You're going to get feeling better about 50% of the way through. But it's so important that you carry out the prescription, that we carry this out to the very end. And these are the components, this is the criteria we're looking at to end your episode of care.
Yeah, it's great right?
Analogy. Because then people know, they understand what an antibiotic is. Mm-hmm. They know that you shouldn't just quit halfway through, that the infection can come back, right? Yeah. And we want people to understand that. Like, your role is to get through the whole plan of care. And we're going to have, at the end, we're going to get you a comprehensive home program of everything that you need to keep working on so this doesn't come back. Yeah. Right? We're going to give you 20 exercises. You're going to pick 3 exercises a day. And this is going to be a really resilient program for you moving forward. But it's the building the bridge to the next thing. And also, we even one step further, we want to get you in a local gym. Like, we want you on a regular exercise routine every single day, whether it be at home, with your kids, whatever it is, at a gym, like doing something that you truly love. Yeah. Because we want to create long-term change for these people, not just fix their pain and send them out, right? Right. Like, we want to create, so we go out and we know the personal trainers in the areas. So we know all of their programming. We know how they talk to patients, so that way we can connect them with those people to create really longevity and quality of life for these people.
Yeah, that's great.
So, any other last advice for patients with low back pain, whether it be chronic, acute, any other things that you hope they would know?
I'd say, just going back to the timing of when to ask for help. If you find yourself using, over-the-counter pain relievers on a consistent basis for, say, 30 days, that's probably a time to say, let's look into this a little bit more.
That's fantastic advice. I totally agree with that, And the one thing I'd add to that is, if you have back pain and you haven't found a solution and you've had a team, find a new team. Yeah. Like, do not give up. Back pain, There's so many different options. We had a full podcast on Reactivate and the value of that, but there's so many different procedures you can do before surgery. But, in my mind, I don't see a lot of reasons other than the 10 to 15% of cases that we talked about earlier that we should be getting surgery, or even thinking about it until you've really gone through all these other things, because you can create such a better life if you just avoid that surgery. There is a time and a place for all of those. Mm-hmm. But let's exhaust the conservative things and not change your original anatomy unless we have to.
Absolutely.
So okay. Dr. Joyal, you're the man. Thank you for all you do for our patients out in the community. You really make such tremendous difference. Remind us how people get in contact with you if they need to.
Our website is asappainclinic.com. We have offices in Tooele and Draper, and give us a buzz.
Yeah, I've loved your name since the beginning, ASAP, because you're thinking like get in ASAP, but advanced spine and pain, like so creative of a name and so awesome. But they are really ASAP. Like they get things done. You hear about these spine clinics that take months to get into. Like Dr. Joyal's team does such a phenomenal job at getting you in as quickly as they possibly can. They fill their gaps if people cancel. Their goal is to get you out of pain and relief as quickly as we possibly can. So
absolutely.
Thank you, Dr. Joyal. Appreciate
you. Appreciate it.